in the gallbladder.
Which one is this?
This can sometimes get confusing, so if you have any questions after or during, please raise your hand or come see me. Because I don't want this to kind of jack you up, but I will try to make this as simple as possible. I know you guys can understand it, but it's just sometimes a little bit confusing. Okay? Alright, so the liver. The liver is what's responsible for making the bile, right? Bile is what we need in order for us to absorb fat, essentially. In the bile, you have a lot of things in there, right? The most important thing you have in there is they're called bile salts. These bile salts, when they're released from the bile, they go to our small intestine, and then we eat something, fat or some type of fat. That bile needs to break down those large fat globules in order for lipase, which comes from the pancreas, to break that down further. Without bile salts, if we were to eat something fatty, it would just go right through us. It would just go right through us. And if that happens, your stool's going to look real greasy. It's going to float to the top. It's going to float in the toilet. So we need bile. We need those bile salts to help break down the fat. That way lipase can come through, which comes from the pancreas, and break that down a little bit further. Okay? So besides bile salts, you have other things like cholesterol. That'll play a big role here when we talk about gallstones. Phospholipids, proteins, direct bilirubin. You have direct bilirubin in there. I'll explain what that means here in a second. And you also have calcium and some other electrolytes. All right, so bilirubin. Bilirubin is what happens whenever our red blood cells break down. When they break down, that heme portion of the hemoglobin gets broken down into bilirubin. There are two different kinds of bilirubin. So the one that we're gonna get from the breakdown of the red blood cells, that's called indirect bilirubin. It's also called unconjugated bilirubin. There's two names for this thing. I'm gonna try to just stick with indirect. If I say unconjugated, I'm sorry, but it's the same thing. It's the same thing. Now, indirect bilirubin, whenever our red cells break down, and that heme breaks down into indirect bilirubin, that thing is not water soluble, meaning it can't just freely float in our blood. It needs to be attached to something so it can go to our liver to be processed. And it's attached to albumin. When it's attached to albumin, now it can float in our blood, go to our liver, and be processed. But because it's attached to albumin, we're not going to be able to filter that thing out in our urine. So we're not going to see any indirect bilirubin in our urine because that albumin's attached to it. And albumin's a protein, and that protein's too big for it to filter out through the urine. Okay? Now when indirect bilirubin goes to the liver, attached to albumin, the liver then takes it up. It takes in that indirect bilirubin, and the liver cells then do something called conjugation, meaning they take off that albumin and they attach another molecule to it, which then makes it capable to be excreted into our gut, into our bile, into our gallbladder. Okay? This direct bilirubin, this thing is water soluble. So if it gets into our blood, we can then urinate it out. You can see a darker urine if that happens. That shouldn't happen though, because it goes to our liver conjugates it, and then what the liver should do is send it to our gallbladder, to our common bile duct, and then to our intestines to be excreted out. Okay? And then liver obviously does a bunch of other things. Makes proteins, detoxifies, meds that we take, but I really want you to focus on that bilirubin. All right, so jaundice. So jaundice, we also call this hyperbilirubinemia. It means you have a lot of bilirubin in the blood or in the body. When you have jaundice, you have a yellowing of your skin and your sclera. Jaundice, you have too much bilirubin in the blood. And when you have too much bilirubin in the blood, whether indirect or direct, doesn't matter, that stuff likes to go to our sclera and our skin because there are proteins in there that thing can attach to. Most of the time, it's going to start in your sclera first. So your eyes are going to turn yellow first. Another name for jaundice is icterus. So that just means the same thing. Jaundice and icterus are the same thing. Now, I told you guys that the liver is responsible for making indirect into direct bilirubin. There's a certain enzyme in the liver cells that's their job, is to make that transformation, right? A lot of babies, when they're first born, those enzymes aren't fully up and running yet. So as a result, a lot of babies, first, they develop jaundice when they're first born because their liver cells aren't making that conjugation quite yet, so you can get this buildup of bilirubin in the blood. That's normal. A lot of children have that. We can easily treat that. We get worried, though, whenever that level gets too high, and I'll show you a picture here in a second, but just because the kids' enzymes aren't working well, we get that buildup of bilirubin, but they'll start working well, and then that bilirubin will go down. When you have jaundice, you have bilirubin in the skin, essentially, right? That bilirubin can cause itching. It's very irritating to the nerves in our skin, right? Worse on the hands and feet because we have a lot of sensory nerves in our hands and our feet. So when we get this itching, you can get it anywhere, but patients who have jaundice, who have this high bilirubin level, they're going to have a lot of itching in their hands and feet. They'll notice it more at night, typically because, think about it, when you're sleeping at night, you're just kind of there, trying to go to sleep, nothing's going on, so any little itch, dot, whatever can kind of get in your head, and so you may notice it more at night. All right. Bilirubin, when it gets conjugated, when it turns into direct bilirubin and it goes to our gut, that conjugated bilirubin is what gives our stool its brown color. Bacteria in the gut transform it into something called stercobilin, which I'll show you guys in a second, and it gives it that brown color. If conjugated bilirubin cannot get into the gut, then we're not going to make that stercobilin. And if we don't make that stercobilin, our stool is not going to be brown. And so then you'll get this acholic feces, which looks like a cream-colored, kind of light-looking stool. So that tells us something is getting in the way, so to speak, of that conjugated bilirubin going into our gut. Something's blocking it. If conjugated bilirubin gets into our blood, which it shouldn't, if it gets into our blood, it's water-soluble. Right? It doesn't have albumin attached to it anymore. So if it gets into our blood, it can be processed out through our kidneys, and we can pee it out. And so if we pee it out, it's going to look brown, because bilirubin is a yellow, dark color, right? And so when it goes through our blood, it goes through our kidneys, we're going to pee it out, and it's going to look brown. That's conjugated. Can unconjugated bilirubin be peed out? No, because it has albumin attached to it. It can't be peed out. But conjugated bilirubin can. Okay? So here's an example of what jaundice looks like. So mostly affects the eyes. If it continues to build up, then definitely it's going to affect the skin and also the mucous membranes. You got this child here. They have some bilirubinemia going on. So we can treat these children with UV light therapy. And when we do that, that UV light therapy can actually break down that bilirubin to where we can excrete it. Because typically this is a buildup of unconjugated bilirubin going on. When we expose the child to UV light, the light will break down that bilirubin, and then we can excrete it out. It's called lumilirubin. You don't have to know that, but it's just another way to kind of bypass the liver if that happens for our kids. Normally, you're not going to have bilirubin or bilirubinemia until you get to a level of 2 milligrams or higher. You draw the blood. If it's greater than that, that's when you'll typically start seeing that jaundice occur. Okay? Normally, it's really low. All right, so let me just kind of. You guys haven't had this in the clin lab yet, right?
No.
Yeah? Maybe? Okay. We're going to assume that. So, all right. The red blood cell breaks down. And it makes what? That heme turns into what? The heme breaks down into unconjugated bilirubin. The globin will turn into amino. The heme will turn into unconjugated bilirubin. Okay? So we got this red blood cell, it's broken down. The heme portion of it is turning into unconjugated bilirubin, which is not water soluble. goes to the liver, right? Albumin is attached to it, takes it to the liver. Liver takes it up. The liver turns it into conjugated bilirubin. It attaches this thing called glucuronic acid. You want to know that, you can. That's what makes it conjugated. From there, it goes into our gut. It goes into our bile, it goes into our gallbladder, it goes into our common bile duct, and that connects to our gut, right? When it gets into the gut, it turns into, or when it gets to the liver, it's conjugated bilirubin. In the gut, it's conjugated bilirubin. Okay? In the gut, you have bacteria that are going to transform this further. Skip this for now. The bacteria in the gut are going to transform conjugated bilirubin into stercobilin. The stercobilin gives our stool that dark color. Okay? In the gut, though, you can get some absorption of conjugated bilirubin, but it's in a form called urobilinogen. It's only a little bit of absorption. It goes to, that can go into your blood, and then when it goes to the kidney, and you urinate it out, it turns into something called urobilin, which gives your urine that yellow color. It's only a little bit. It's only a little bit. You're not going to get a lot of absorption. Okay? Does that make sense? Okay. All right, so when we have an increased amount of bilirubin being produced, we already talked about it. If your red blood cells break down, you're going to get that heme that turns into an indirect bilirubin. If you have a lot of RBC breakdown, you have sickle cell disease, you have malaria, you have autoimmune hemolytic anemia, something that's a transfusion reaction, right? Something that's causing a lot of RBC breakdown, you're going to get a high bilirubin level. It's going to be an indirect though, okay? And I'm going to break down even further once we go on. That's called pre-hepatic, so it happens before the liver. If the liver is the problem, if you have cirrhosis, if you have hepatitis, if you take a ton of Tylenol and your liver's inflamed now because it's trying to detoxify all this Tylenol, the liver is the problem because the liver is what takes in the indirect bilirubin and the liver is what transforms it into conjugated bilirubin. So if you have a damaged liver, you're going to have a hard time taking that indirect bilirubin and transforming it into conjugated or direct bilirubin. But also, if the liver is damaged, it can't secrete that conjugated bilirubin effectively. It may still be able to make some of the conjugated bilirubin. It's damaged, it's having a hard time doing that. But the stuff that it can conjugate, it's going to have a hard time secreting that into the GI tract. Okay? I'll show you what I mean here in a second. But the problem is the liver. It's called hepatic. It's hepatic cause. Post-hepatic means after the liver, right? The liver's fine. The liver works well. It's taking that indirect bilirubin. It's conjugating it, making it into direct bilirubin. But when it tries to secrete into the gallbladder, the common bile duct, the intestines, there's something in the way blocking it. It can't get past that blockage. We call that cholestasis whenever bile flow is not going through. A lot of times, this is going to happen if you have some type of obstruction, like you have a gallstone in the common bile duct, or if you have a tumor in the pancreatic head. So the pancreas, right, that pancreas kind of sits right there, that common bile duct goes into it. If there's a tumor, if you have cancer in the pancreatic head, that can block it as well. If you have a tumor in the pancreatic tail, which is not near that common bile duct, are you going to have blockage? Probably not. Probably not. But if it's in the head of the pancreas, it's going to block that flow. It's going to increase our bilirubin. It's going to be conjugated bilirubin because the liver processed it. Okay? So if you were to draw labs on a patient, you would see that if they had a pre-hepatic cause, they would have an increased indirect bilirubin. If they had a hepatic cause, they would have both indirect and direct that are elevated. And if it's post-hepatic, they would have an elevated direct bilirubin. Okay? Let's break this down more. So when you order a lab test, most of the time they're gonna, depending on which lab you get, most of the time they're gonna tell you the total bilirubin level. That total bilirubin level is just a combination of indirect and direct, right? So you may not, in real life, you may not get the direct and indirect levels, but you'll get the total. If you see a total that's elevated, you have to figure out why that's elevated. You have to figure out, okay, my total is elevated. I don't know, is it the indirect or the direct? I have to figure out why. So then typically what you'll do is you'll order additional labs that will tell you which value is actually high. I'm going to give you, if I give you this and on test, I'll give you everything, right? Obviously, you can't order a lab, but you're gonna have it all. But every one of these causes, they're going to have a high total bilirubin. So just know that, right? Now you have to figure out why. So when we have an increased RBC destruction, we have hemolytic anemia, we have sickle cell, something's causing those RBCs to break down. That indirect bilirubin is going to the liver. Okay? The liver can only process so much indirect bilirubin. It has a limit. And so as it's trying to do that, so maybe it can normally process 5 molecules of indirect bilirubin, right? But now we're given 10, 20. The liver still works. It's still going to process that. It's just going to take a lot of time for it to do that. As a result, that indirect bilirubin in the blood is high because it's waiting for the liver to accept it for it to come in. Once it comes into the liver is doing its thing and it's pushing it out into the gut, right? So if you were to draw this person's blood, they would have a high indirect bilirubin level, but their direct bilirubin level will be normal because it's not going back into the blood. It's just a backstop. It's just waiting to process the indirect that it has to direct, push out to the gut, but it's not going back into the blood. But because we're processing so much indirect bilirubin into direct bilirubin, you're going to have an increased amount of direct bilirubin going into the gut. So as a result, you're going to make more circle bilirubin. And as a result, your stool is going to be darker because that's what gives it that color, right? So blood level of direct bilirubin, normal. The stool is going to be darker because we're processing more of it, making more circle bilirubin, which is causing a dark stool. The urine is not going to change though. The urine is going to be normal color. It's going to be normal color. It's not, the direct bilirubin is not backing up into the blood. So when you pee, it's going to look like a normal yellow color. Okay? Does that make sense? So hepatic cause, right? So the liver is damaged. Something's going on with the liver it's sick, there's some type of inflammation, there's something, right? When you draw this patient's blood, they're going to have a high total bilirubin. We know that already. But because the liver has a hard time conjugating that indirect bilirubin into direct, it can still do it, it just has a hard time. You're going to have a high level of indirect in the blood. It doesn't work that well. But the liver is damaged as well, so any conjugation that it's able to do, it's going to have a hard time pushing that into the gut because it's damaged, right? So it's going to start backing up into the blood. The liver is taking that indirect, turning it into direct. Barely anything that it makes, it's going to push it back into the blood because the liver is damaged and they can't push it out into they can, but not as effectively into the gut. So as a result, both your indirect and your direct, if you draw this patient's blood, both the indirect and direct bilirubin are going to be high. If you look at their stool, it's going to be a lighter tanner color because you're still pushing out some direct bilirubin to the gut, just not efficiently. And so that stool is not going to get as much circle bilirubin, so it's going to be lighter than normal. It's going to be tan.
Sir, did you say unconjugated or conjugated is the one that's being bumped back into the urine at this point?
The conjugated.
Conjugated is.
You have a high level of unconjugated still, but now you're pushing conjugated back to the blood. Now, conjugated bilirubin is, or direct bilirubin is water soluble, right? So when we push that into the blood, now we can pee that out. When we pee, that urine is going to be darker. It's going to be like a brown kind of tea color, because that stuff's water soluble. Cool. Okay. Now the posthepatic, right? The liver works fine. The liver can conjugate, can turn indirect into direct. It can make that, it can do that conjugation, but there's something blocking it from getting into the gut. A tumor in the pancreatic head, not the tail. The common bile duct. Go ahead.
I'm sorry, sir. So hepatic jaundice, right? It's impaired function of the hepatocytes.
Right.
So shouldn't there be a decrease in direct bilirubin? Since
It's impaired, but it can still process it. It can still, it doesn't work as well, but it can still conjugate that bilirubin.
okay, so there's a
The liver's not dead, right?
right. So there's a backup, if you will, in direct bilirubin because the hepatocytes are not functioning optimally.
Right.
So it's not processing it as fast.
Right.
So it's still processing it. So we still have direct bilirubin.
Yeah, it is still processing it, but it has a hard time pushing it out to the gut. The liver cells are not working like it should. Okay. I know that one's kind of. If it doesn't make sense, let me know. Okay. 'Cause hepatic is kind of confusing. Okay, post-hepatic. Something's blocking it, right? The liver's working fine. The liver works well. It's taking that indirect bilirubin. It's turning it into direct bilirubin. It's trying to push it out to the gut, but there's something blocking it. And because there's something blocking it, there's some type of stone, tumor, whatever. It's going to start backing up, back into the blood. Okay? When that happens, your indirect bilirubin, if you draw a lab on this patient, your indirect bilirubin is going to be normal because the liver can still process it, right? But the direct bilirubin is going to be high because it can't exit to the gut, so it's going to back up into the liver, to the blood vessel of the liver, and go back into the blood. So then that direct bilirubin is going to be high. The liver processed it, tried to push it out, couldn't, now it backs up. When you look at this person's stool, because they're not pushing out that direct bilirubin, it's they're not making that circumbilin anymore. That stool's going to be very, very light. It's going to be acholic, right? It's going to look creamy, like a clay color is what we call it. Yeah? You're not pushing out that direct bilirubin to the gut. That urine is going to be very dark though, because it's backing up into the blood. That stuff is water soluble. And so now when you go and you pee, because it filters through the kidney, it's going to be very, very dark, cola color, darker than the hepatic cause. Cool? All right. So putting it all together, so prehepatic, again, RBCs are breaking down too fast. You're making a lot of indirect bilirubin. The liver is doing what it can and it's processing it. But it just takes a while, so that indirect's going to back up. But you're not going to have a lot of direct bilirubin because the liver can still process it. It's not backing up to the blood. When it goes to our GI tract, you're making a lot of circobilin, which is turning that stool a lot darker than normal. But because that direct bilirubin is not backing up into the blood, your urine's going to be normal. The hepatic cause, the liver is damaged, is trying to take in that indirect, trying to conjugate it, trying to transform it, has a hard time doing that, so you're gonna have a high indirect. Because the liver cells are damaged though, it has a hard time pushing into the gut. It can a little bit, it can, to a certain extent, but it's also going to cause that direct bilirubin to back up into the blood. So when that happens, your urine's going to be darker, not that dark, tea color, right? And the stool's going to be a little bit lighter because we're not pushing as much directly of the rumen into the gut, so our stool's going to be lighter. The post-hepatic cause, something's blocking it, right? The liver can still transform the indirect into direct. It can push it out into it can try to push out to the gut, but it can't because something's blocking it. So that direct's going to back up. So the direct's going to be high in your blood. The indirect's not going to be high because the liver still processes it. But as a result of it not getting into the gut, that stool's going to be very cream colored, very, very light, and the urine's going to be very, very dark. Cool. All right. If you have any questions, come see me. Okay. So, where are we at? Hepatitis. So hepatitis, all that means is that the liver is inflamed, right? Liver inflammation. There are certain pathogens, certain viruses that can cause this. Hepatitis A, B, C, D, and E, right? Other viruses can cause this too. Epstein-Barr virus definitely can. I'll tell you guys a story later on about that. But just worry about A, B, C, D, E. When somebody has hepatitis from A, B, C, D, and E, one of those viruses, right? We can break it up into whether they have an acute or a chronic form. Acute hepatitis means that they have this infection for less than 6 months. Okay? Let me kind of backphrase. The only things that can cause acute hepatitis, out of the hepatitis I talked about, A, B, C, D, and E, only A and E. How can I phrase this? A and E can only be acute. They don't turn to chronic. Okay? For chronic hepatitis, this is when you have hepatitis for longer than 6 months. You worry about this with B, C, and D. These can definitely turn into chronic. Can you have acute B, C, and D? Yes, you can. But B, C, and D can also turn into chronic. A and E doesn't. And those are on other slides here, so I just want to make you guys are. Now with chronic hepatitis, because you have this infection, that virus is in the liver cells, it's replicating, as much as it can. This stuff is very, very transmissible. If you get in contact with hepatitis that's in the blood or secretions, you have a potentially high likelihood of getting this infection as well. When you have chronic inflammation of the liver from hepatitis, it's going to cause a lot of liver damage, which may eventually turn into cirrhosis, and I'll talk about cirrhosis towards the end. All that means is that the liver is fibrotic and scarred and not working well, which can then turn into liver cancer. So chronic hepatitis we are concerned that somebody will develop cirrhosis or liver cancer when they have chronic hepatitis. There's also something called a carrier state where somebody has a chronic infection, but their liver is not inflamed. And this is kind of tricky because some people have hepatitis and they don't know they have it, and then they go and they try to donate blood, which we screen for, thankfully, or they have unprotected sex or whatever, right? And they could actually pass this off to other people because they don't know they have it. And then there's something called fulminant hepatitis. This is a very, very rare liver death, essentially. Most of the time it's associated with hepatitis E, and most of the time in pregnant women. And I'll talk about that here in a few slides. But what happens here is the liver cells are severely damaged. They die off very quickly, and the patient ends up actually dying from this. Unless they get a liver transplant. Okay, hepatitis A. Hepatitis A has an incubation period for 2 to 6 weeks. That means that you have this virus, but it's not showing any symptoms yet. So it's inside of you, replicating, incubating, but you're not symptomatic yet. That can range from 2 to 6 weeks. However, once you start having the symptoms of this, most of the time after a few days, you're better. This is typically from fecal-oral contamination. So somebody has this virus, they didn't wash their hands right, they made your food, maybe they didn't know they had it quite yet. They give it to you, you eat it, now you have this hepatitis A, and it's going to cause fever, it's going to cause liver inflammation, some jaundice, loss of appetite, diarrhea as well. But this is kind of like, it kind of presents like a gastroenteritis, like a bacterial gastroenteritis, right? This person just looks like they have a GI bug, but they also have jaundice, which is not normal for gastroenteritis. So we worry about this for people who, especially in our military folks, who go to other countries and maybe their sanitation is not the best, and so they're at increased risk for this. Now, thankfully, there's a vaccine for this. Hepatitis A has a vaccine. That's good. We can have vaccines, great. Circle that. It has a vaccine for it. Hepatitis B. Hepatitis B is a different type of hepatitis, but this one, we worry about the chronic state with this one. But when somebody has hepatitis B, there are 3 phases to how they're going to present. They're going to have that pre-icteric, which means they don't have jaundice, right? This kind of weakness, vomiting. They may have liver enlargement from that inflammation of that liver being infected. You push on it, it may be tender. And then as it progresses, it's going to turn to the icteric phase, meaning the patient's going to develop liver jaundice, they're going to develop jaundice, and they'll have some elevations in their liver enzymes. Don't worry, we don't talk about liver enzymes here, but you will in the lab. The liver's going to be angry, okay? And then the last phase is the convalescent phase. Now, most of the time, people are going to get hepatitis B and they're going to recover. They're going to be, they got it, they got over it, and they're good to go. 90% of the time. 10% can be chronically infected. So for those 10%, they don't get rid of it. These liver cells are infected and that virus is replicating, and they now have chronic hepatitis B. We get this from exposure to blood and body fluids. So we have to be careful if you're working around blood or body fluids that you don't stick yourself with a needle or get in your eye, because this is how people get exposed. Also, sexual secretions have hepatitis in it. And so if you don't know you have this and you go and have intercourse with somebody else, you can pass it that way. So you got to be super careful with this. Now again, this one has a vaccine. A and B have a vaccine. Good. All right, hepatitis C. Very similar to hepatitis B, but the symptoms aren't as pronounced. So somebody can have this and not know they have it, because they may not have any symptoms, or they may have very mild symptoms. Maybe they thought they had like a GI bug or something, and that was it, right? But the thing about hepatitis C is that it very often turns into the chronic phase. Very often, 80%, right? Out of those 80%, 20% of those folks can potentially develop cirrhosis from that chronic inflammation, which may eventually turn to liver cancer, right? This is the most common cause of liver damage, if you will, in the Western world. The most common transmission for this is blood. So needle sticks are very, very important. Can you get it other ways? Definitely. Sex, if a woman has it and she's delivering and that baby's exposed to it, the child can get it. We used to, back in a long time ago, like in the 90s, there was a big problem with blood transfusions because they had a hard time trying to find this in people who donate blood. Now they have now that's probably like 0, I would imagine. Because we screen for hepatitis and a bunch of other pathogens whenever somebody donates blood. It used to be a thing. Now, there's no immunization for this one. We can't vaccine against this one. So you got to be very careful. There's no protection, if you will. There's no vaccine. All right, hepatitis D. Hepatitis D needs hepatitis B to infect you. Okay, it's dependent. There's 2 different types of infections, if you will, that can happen. If you get hepatitis B and hepatitis D at the same time, it's called a co-infection. Okay? The good thing about a co-infection is that oftentimes our body can clear it because the liver is still healthy, it's attacking at the same time, and so we can still try to clear this, and it's very uncommon for this to turn to the chronic state. If you have hepatitis B first, and your liver's already jacked up and damaged, and then you get hepatitis D later on, that's called a superinfection. When that happens, because the liver's already damaged from the hepatitis B, you have an increased risk of developing liver cirrhosis and cancer because the body has a hard time trying to fight this whenever the liver's already messed up. So superinfection just means that you're at increased risk of having cirrhosis cancer. Same thing. Symptoms are similar to hepatitis B. That you get it in blood and body fluids, but again, there's no vaccine for this. You can't vaccinate against this. Now, if you get the hepatitis B vaccine, will that help? Probably, right? But there's no singular vaccine for hepatitis B. Okay. Hepatitis E. This is very kind of similar to hepatitis A. It's spread through fecal oral. Somebody has this. They serve you food. They didn't wash their hands, and so you ingest it. But most of the time, it's self-limited. You get this, you get jaundice, a little fever, maybe some diarrhea, and then you're better after a few days. The only people who should be concerned about this are pregnant women. Pregnant women, if they get hepatitis E, especially towards the end stages of pregnancy, they're at a greater risk of developing some of that fulminant hepatic necrosis, where those liver cells become super damaged. They start dying off quickly. And once a bunch of liver cells start dying off quickly, you're not making albumin, right? You're not making clotting proteins. So these women can die from that. So this is really associated. We really worry about this when a woman is pregnant. She develops this. Okay. Again, there's no immunization for this. You can't vaccinate against this. All right. So biliary cirrhosis. So biliary cirrhosis. All this means is that there is damage to the liver caused by the biliary system. So the stuff that help, that the liver drains the bile into, those cannuliculi, what accept that the bile, those drain into the hepatic duct and the common bile duct, right? The intrahepatic, so for primary biliary cirrhosis, it's an autoimmune disease. It typically occurs in women, 30 to 65, and the immune system attacks the intrahepatic bile ducts, so the ducts that are inside of the liver. It destroys them. And when it destroys them, that bile is going to leak out of them. Now, the liver makes bile, right? But the liver is making it and it's pushing it out. So it's making it, it's pushing out. When that bile is leaking out from those ducts and it starts to get on those liver cells, that stuff can actually be toxic to the liver. It can actually start causing damage to the liver. It's like a detergent. It breaks down the walls of the hepatocytes. So then what happens? The liver gets inflamed. It tries to repair itself, but it can't repair itself well. So then scar tissue starts developing. So that's what leads to liver cirrhosis. That scarring of the liver, because the bile leaked out of those bile ducts, got into the liver cells and caused damage. That's primary biliary cirrhosis. Secondary biliary cirrhosis is where you have obstruction of the common bile duct. Something's blocking it, right? Now, those bile ducts, they're made to have bile in them, right? But the longer that stuff sits there, the more damage is going to occur. Because like I said, it's a detergent, it can break down those bile ducts if it just sits there. So when we have something blocking it and that bile is just sitting there, it can actually destroy those cells, cause a backup because something's blocking it, but also destroy the cells. And as a result, that bile is going to back up, exit that bile duct, get into the liver, and cause liver damage. When that happens, the liver is going to be inflamed, it's going to be fibrotic because it's trying to repair itself, and then you're going to get cirrhosis that way. And then primary sclerosing cholangitis, that's an autoimmune disease. Typically we see in men. Typically we see it in irritable bowel disease, more commonly ulcerative colitis and Crohn's. And what happens here is that the immune system attacks those intra and extrahepatic ducts, so both inside the liver and outside the liver. When it does that, it causes scarring. And when it scars down, bile can't flow like it should. That can actually lead to that secondary biliary cirrhosis, where it starts to damage the bile ducts, starts to back up, leak out, cause damage to the liver. It can also cause cancer of the bile ducts as well, because that chronic inflammation can start causing mutations and cause cancer to those cells. This thing's hard. This thing is, you have to really be searching for this in real life if you think this is happening. Because most of the time when this happens, you're going to think something else is going on with the liver. Until you do an additional workup, get some specialized imaging, it's kind of hard to identify that this is the cause. So these patients are going to have very vague symptoms. Okay, cirrhosis. This is what you'll probably see more often. So cirrhosis just means that there's liver inflammation, liver scarring, fibrosis, damage, right? When somebody says that they have end-stage liver disease, they're saying they have liver cirrhosis. That's what that means. The most common causes of liver cirrhosis are alcohol, hepatitis B, and hepatitis C. So with liver cirrhosis, it takes a while for this to happen, right? There's, something's causing damage to the liver cells are dying. When cells die, the body tries to repair them, and instead of making liver cells, it puts down scar tissue, right? So fibrosis forms. The surviving liver cells see that their friends are dead, and they start to replicate, right? They try to regenerate, try to make up for all those dead hepatocytes. But the problem is that this scarring that occurred kind of traps them in there. It traps them in their place, and so they can't regenerate like they're supposed to. As a result, with these regenerating hepatocytes being trapped by the scar tissue, you're going to start getting these nodules, these trapped hepatocytes. And I'll show you a picture here in a sec. But the problem with this is that when you have all this scarring going on, the liver, those cells are dead. They're not making liver stuff anymore because they're scar tissue now. The ones that are surviving are trying to replicate, but they're being trapped, so they have a hard time doing that as well. So that liver is going to be very, very stiff. It's going to be deformed. And when that happens, it can start to compress the blood vessels in the liver. And when it does that, it can cause something called portal hypertension, where you have this impact of the blood flow in the liver because the scar tissue is pushing into it, kind of blocking it. And so that blood that's trying to flow into the liver is being backed up, causing an increased pressure in the hepatic veins. So that's portal hypertension. So here's what I'm talking about, right? So you got this scar tissue, used to be liver cells, but those liver cells are dead, now they're scar tissue. And you got these other liver cells that are trying to replicate, right? Trying to make up for these lost liver cells, but they're trapped by all the scar tissue. So as a result, you start getting these little nodules outside the liver and inside the liver. So it's not just a surface level thing, it's inside deep as well. And you get this fibrosis from those hepatocytes being trapped. So you get these little nodules. When that happens, when that liver is stiff, it's pushing into the blood vessels and it's causing that portal hypertension. All right, portal hypertension. So we already talked about how that forms, right? When that happens, when we have an increased amount of pressure in our portal veins, what's going to happen? We're going to get that hydrostatic pressure increase, which is going to cause that transudative effusion, right? It's going to be pushing out because things are blocked. We're increasing that pressure. That now it has nowhere to go, so it's going to go out to our abdomen, and we're going to get ascites. On top of that, think about the liver. If the liver is already cirrhotic and damaged and not making liver stuff anymore, are you going to be making albumin? Probably not. Probably not a lot of it. And so that's going to contribute to the development of ascites, that swelling in the abdomen, that fluid in the abdomen. Because the blood flow is blocked, right? It's backing up. It's going into our splenic vein. And when that happens, that spleen is going to enlarge because that blood can't flow through it anymore. It can't flow from it. So it starts backing up and causing splenic enlargement, splenomegaly. This portal systemic shunt. So the digestive tract, the blood that flows from there goes to our liver, right? We need that to happen because we need to absorb all the nutrients that we're breaking down in our GI system, and that blood's going to go to our liver. The systemic blood, right, the stuff that's not digestive tract, that goes everywhere else. They're connected, but they're separate. So GI blood flow has to go to our liver so our liver can process what we tried to absorb, and then it takes it to the inferior vena cava and then to the heart and processes out. Systemic flow, like blood flow to your skin, to your head, all that, doesn't go to the liver, right? But they're still connected. If you have portal hypertension, and that portal flow is backed up, it's going to start going into that systemic flow. So as a result, you get this thing called portal systemic shunting. So the portal blood flow is now going into the systemic blood. And when that happens, you're going to start causing dilation of veins where those junctions meet, where that shunting meets, right? So esophageal varices, this is what happens with esophageal varices. You have this increased blood flow, you got this blockage, it's going to that area where they connect, now you get this dilation of the esophageal veins. It can happen in the rectum as well, and you get hemorrhoids. There's actually a vein around our belly button that normally doesn't really get much blood flow, but when this backup happens, it can actually cause blood flow to those veins around our belly button. It's called something called kaput medusa. So it looks like just dilated veins on the abdomen. I'll show you here. This guy right here, pretty nasty. This is because that portal system is having hypertension. Now we're getting this backup of flow, which is causing either ascites or kaput medusa, esophageal varices, splenomegaly, or the hemorrhoids. They're very common with this. All right. Let's take a 10-minute break before I roll through this. Or you want to keep pressing? Press? Press? Okay. Y'all got a break? Y'all can keep pressing. All right, guys. So, steatohepatitis. So with this guy, there's liver inflammation because there's too much triglycerides in the liver. I'll take a break. 5-minute break. Not distracting.
Smells good.
Staging beef. Shoot on it later.
I'd like to do the JMU, I just don't want He used to do a lot of good shit. They don't really send me work on that. He works in the hospital every Friday. Really? Dude. That's what the break was like. And it was like, hey, could you move? The job is moving. Stop being doing that and stuff. So he works in New York. His boss signed up. That's how he like if they're not in the, what he was briefing was like, the weekend series, like their range time is actually going to range their range time. Yeah, it's a hospital. So all of them work in civilian hospitals. Doing surgeries and all that shit. That's their full-time job. They do a lot of admin stuff. All those sorts of things. You know what they're there for. All of them. You babysit like adults. Yeah. But it's not like legit babysitting. Like if someone wants to be on it. It's not like the surgeons that you see in regular mental health. Guys are using BHA. They're trying to keep that shit going so they can go do stuff.
Yeah, because they probably went to that unit to deploy and do all that shit.
Yeah. It's babysitting. Not really.
Nick's also probably used to babysitting as like normal RE stuff.
It's a difference.
What is the Annapolis? That's soft.
One of the like training units, I guess. One of the action units.
I'd heard that once.
Chevy Cruise. Hey, no scratching, huh?
Maybe I should bring the show.
Be good to me.
Yeah, so it's kind of weird.
I would recommend finding parts a little bit further out.
Like they had Jake, who was like, let's see what kind of scene they he did a lot of contracting with SF.
I asked them what brand t-shirt they were getting, and they told me some random brand. So I got an extra large. So it's just like big as hell. Probably a little baggy. I have no chocolate. Look for a sweet treat.
But yeah.
Almost there. I ate a big ass piece of that dark chocolate.
No, take it.
No, I'm good. That's it.
You gotta tell me what my fortune is, though.
I need a sweet treat. That'd be even funnier.
I'll let him.
Doktor. Doctor.
Yeah, you know, our kid. That was pretty sick.
Almost there.
Gotta stomp this one.
Deal.
1, 2, 3, 4, 5, 6, 7. Rad, barn, 2 days of that.
Not out of town that weekend for a wedding and my buddy's bachelor party. I need to try.
Woo! Better read after class. Damn, he couldn't save for that yellow space? Oh, his wedding's that weekend too?
Not his wedding, it's another friend's wedding. But I've missed so many weddings, I was like, this is one I was like, I gotta make it. But
So did you know that fortune cookie, like what you do after the what? So you say it in bed after it, so you're never too old to learn something new. You always say that because like they suck. None of us. That's what I'm saying.
I only got like 9 more spots. I'm trying to have an actual real long Friday evening.
One minute.
You gotta be louder than that.
Be louder than that, come on.
But
1 minute.
a little louder for the people in the back.
For the people in the back. For the Marines doing pull-ups. We got one.
Alright, I wanna go home too, so y'all ready?
Yes.
Alright, Alright, fighting liver inflammation, steatohepatitis, a lot of your patients are going to have this for sure. That's out there. What happens here is that the liver, one of its jobs is to store fats, right? The most common storage form of fat, if you will, are triglycerides. Triglycerides can be broken down later on to be used as energy. When there's too much triglyceride, too much fat in the liver, obviously you're going to have hepatomegaly because you have a lot of fat in there. It's going to grow big. It's going to look greasy. It's going to look like yellow, right? Because these triglycerides, these fat molecules are yellow. Alcohol can do this, and essentially something called metabolic syndrome. Essentially, your very unhealthy patients, this can cause it as well. When it's due to alcohol, we call it alcoholic steatohepatitis. When it's due to metabolic syndrome, which means this person they're obese, they have a high waist circumference, they have high blood pressure, they have high triglycerides, they have low HDL, they have high blood sugar. This is somebody who's not living well. When it's due to that, we call that non-alcoholic steatohepatitis. Now the thing between these two is that you can't tell which is which if you just were to biopsy it. They look the same, because essentially the same thing is happening. So the way you tell is based off history. You talk to the patient, you see their vitals, you see their labs, you ask them if they drink a lot, hopefully they tell you the right answer or the truth. And based off that is how we determine it. But when we do a biopsy of the liver, it's going to look the same. You're going to see, in this one that says NASH, right? This could look like ash as well. You see these kind of globules of triglycerides. So really you're going to, these triglycerides, when they start breaking down, if you have too much room in the liver, the liver starts making these kind of toxic substances from the triglycerides, which cause that liver damage and cause that liver inflammation. It could eventually lead to liver cirrhosis. So chronic, unhealthy lifestyle can cause this. Drinking alcohol excessively can cause this. Hard to say which is which unless you get that history from the patient. All right, hereditary liver diseases. So Gilbert syndrome. So Gilbert syndrome is pretty common out there. They're going to aggravate you whenever you get these patients because they're going to have a high bilirubin level and you're going to be like, why is it high? And you got to do this kind of a small workup and then you'll figure it out. But with these folks, they don't have this certain enzyme called UGT. UGT is what helps turn that indirect bilirubin into direct bilirubin. It's what conjugates it, this enzyme, right? If they don't have a high enough level of this enzyme, whenever they have an increased production of indirect bilirubin, which we all make indirect, right? Whether they're stressed, whether they're sick, whether they're working out, something like that can increase that indirect, which normally, people who have a normal UGT level, we can process that and then push it out and we're fine, right? These folks, they have a decreased amount of activity of that enzyme. So when we have a bump of indirect bilirubin, this enzyme's gonna have a hard time trying to conjugate it. It's still gonna do it eventually, right? It's just gonna take longer and it's gonna be slower. But during that time, when that patient comes to see you, you draw their blood for whatever reason, they're gonna have a little bump in their total bilirubin, and then whenever you check their blood, if you decide to work it up further, you'll see that indirect's high and it's only a little bit high. They're gonna have a little bit of jaundice, but then give them some time, whatever caused this will eventually resolve and then they'll get better and they'll resolve. Bottom line is you don't have to do much for these people. You just kind of have to figure it out, say, okay, no problem, it's not gonna harm you. Especially if it's only for a little bit, then it'll get better. Alpha-1 antitrypsin deficiency. So we talked about this already with the emphysema. Remember that? If you don't have this can cause emphysema in those young individuals. It can also cause, if you have a deficiency in this enzyme, this deficiency in this enzyme, it can also cause liver damage, liver inflammation, which can lead to liver cirrhosis as well. So if you have a deficiency in that, it can cause emphysema and liver cirrhosis and damage as well. Hemochromatosis. So with this guy, there's a defect in the person where they absorb too much iron. Normally we have to kind of keep a certain level of iron in our blood. With these folks, they just keep absorbing it. They ingest it, it gets into their small bowel, and then that small bowel just says keep coming. It keeps taking it in. The problem with iron is that if you have too much of it, it can be toxic to your cells. It can cause reactive oxygen species. If you remember that from back block 1, I think. When it does that, it can damage a number of cells to include the liver, but the pancreas, the heart, a lot of issues, right? When you have too much iron in the blood, it's going to cause damage to those tissues that it starts to kind of precipitate into. If it gets into the liver, it's going to turn the liver brown, so we call that pigmentary cirrhosis. It's going to look like a rusty brown appearance because you have iron in there, too much of it. If it gets into the pancreas, then, I'm sorry, yeah, if it gets into the skin, it can cause your skin to be like a kind of a darker color. And then if it gets into the pancreas, it can destroy those beta cells which make insulin, so you can become a diabetic as well. So they call that bronze diabetes. So somebody who's has a kind of weird pigment to them, and they're diabetic, we call that bronze diabetes from that iron causing that damage. It can also cause issues with the heart and cause a heart failure. When you run labs on these people, they're going to have a high serum iron level. I hope that makes sense. They have too much iron in the blood. There's something called a transferrin saturation. So transferrin is a protein where the iron that normally takes iron and transports it around the body, right? So it's called transferrin. The more iron you have on transferrin, the higher it's going to be saturated. So there's going to be more molecules on that transferrin. So when you run that blood test, it's normally given as a percentage. You'll have a higher percentage, a higher transferrin saturation percentage, because there's so much iron on that transferrin that's taking up more spots on that protein. Okay. The way we treat it, or liver biopsy, if you were to do liver biopsy, you would see these iron deposits. And then the way we treat this is that we just take their blood. We do frequent phlebotomy. Because iron is stored in the blood mostly, right? It's stored elsewhere, but mostly in the blood. So if we take out the cells that normally store this, we can decrease their iron level. We can also give them metal binding agents. These are pills that they can take that will help kind of trap that iron, if you will, and help us excrete it out through our urinary bile. Now, iron is a what? It's a metal, right? So if you have iron toxicity, you have metal toxicity. Metal toxicity, right? Metal toxicity. All right, that's what this looks like, hemochromatosis. So you get this bronze diabetes, causes a lot of issues elsewhere, can cause liver damage, liver cirrhosis. So not good. With Wilson's disease, this is a problem with copper. So in our hepatocytes, in our liver cells, there's this protein. You don't have to worry about the protein name. It's called ATP7B. This protein takes copper in our body, in our liver, and it pushes it to, normally pushes it to something called ceruloplasmin, which takes it out and helps us get rid of it. Or it can actually make these vesicles around the copper where it can now go into our bile and be excreted. When we take out this protein, we can't do it anymore. When that copper builds up in the liver, that liver becomes damaged, right? The liver starts to die off because that copper, very similar to the iron, this copper makes those free radicals, starts to damage those liver cells. As a result, it starts to leak into our blood. When we have a high amount of copper in our blood, it causes a lot of issues. It causes copper toxicity, causes metal toxicity, right? Some features that you may be able to see on a patient are what are called Kayser-Fleischer rings, where you get these kind of copper deposits at the periphery of the cornea. So you kind of got this like golden ring around your eye, right? If it goes into the brain, it can cause movement disorders. It can also cause, some people can have trouble like tremors, or they can have trouble talking, or they can have trouble walking. It can cause mood changes as well. It can cause depression, anxiety, all kinds of just weird changes in the brain. The way we're going to find this is by doing a liver biopsy. That's the best way to do it. You take a biopsy of the liver and you can see these copper deposits. We treat these, though, we can't just do phlebotomy for these guys. We have to actually treat them with metal binding agents, chelating agents. All right, gallbladder. All right, so when you have gallstones, we call that cholelithiasis, right? Gallstones in the gallbladder, the stones in the gallbladder, are called cholelithiasis. When those gallstones go into the common bile duct, we call it choledocholithiasis. The name changes. It's still a gallstone, it just depends on where it's at. Okay? We make gallstones for a few different reasons. We have too much cholesterol in the bile in our gallbladder. That cholesterol can start to precipitate. If there's too much of it, it can start to precipitate and turn into this kind of rocky stone, right? If we have too much bilirubin in the bile, maybe we have a lot of RBC breakdown, we're making a lot of conjugated bilirubin, and that goes into the bile. If there's too much of it, that can cause it to precipitate as well and cause these stones. those bile salts that I talked about, which are very important in breaking down fats, right? If we don't have enough of them, typically we'll see this in Crohn's people because their small bowels are messed up. If we don't, or we're not making enough of these bile salts, then that too can cause these precipitations from the other stuff that's in there because those bile salts help kind of keep things, liquid, if you will. And if the gallbladder is not moving, if it's not contracting and pushing out the bile, so if we have gallbladder stasis, then if that bile just sits in the gallbladder, it starts to absorb a lot of water, which makes it more concentrated, which makes it more prone to precipitating, which makes it more likely to develop a stone in there. Okay. Now we can figure out what kind of stones. If we figure out what kind of stones they have, we can figure out where the problem is, right? And most of the time, when somebody has a gallstone in the gallbladder, if they're symptomatic, we'll take that thing out and kind of see what it is. If they're yellow or brown looking stones, so yellow to brown, right, then they're mostly cholesterol stones. Risk factors for these, so this is, I didn't make this up, this is a true thing. The 4-4, so 40 fat, fertile female. 40 because as you get older, that gallbladder doesn't work as well, and so you're more likely to get that stasis. The fat, think about people who are obese, they don't tend to have the best diets, their cholesterol tends to be high, so they're pushing out more cholesterol into that gallbladder, which is going to make that concentrated, which is going to make that stone. The fertile in the female, so estrogen plays a big role in pushing cholesterol into the gallbladder. So women obviously make more estrogen, so they're more prone to pushing out cholesterol into their gallbladder, which is going to make that precipitate. Progesterone also actually causes the gallbladder to not work as well. We'll just say that, right? Women, it's still going to work for you, right? If you have an increased amount of progesterone, that can actually cause that gallbladder stasis. When you're pregnant, when you're fertile, right, your estrogen and progesterone go up. It goes up when you're pregnant. And so it's very common, actually, for a pregnant woman to develop a gallstone. I've seen it quite a few times. The pigmented stones, so black stones, think about bilirubin with that one. You have an increased amount of RBC breakdown. If you have too much bilirubin that goes into the gallbladder, these stones are going to turn black. It says 50% are radiopaque, meaning you can see them on X-ray. Take that for what it is. I don't know. Sometimes you can see them on X-ray, sometimes you can't. I don't think that's really important, but sometimes you can see that. The brown ones, so these are typically from some type of infection, typically some type of parasite. Typically you'll see that in Asia where these parasites are typically located. But they turn a different type of darker brown, not the yellow brown. Here's an example of what gallstones look like. So this picture here, this right here is an ultrasound. This is how you typically identify that somebody has a gallstone. This is the gallbladder. You have bile in there. This sludge right here, as that bile just sits in the gallbladder, it's going to start to suck out the water, right? The longer it sits there, the more water is going to be sucked out of it. It starts to turn into this sludgy kind of thick material, thick fluid. That's what kind of starts first, and then the gallstones develop. So the sludge starts first, then the gallstones develop. And then here's a picture of an X-ray that you may be able to see maybe that. All right, cholecystitis. So you can have an inflamed gallbladder, which is what cholecystitis is, from a stone, or you can have a cholecystitis without a stone or with a stone. There's different kinds. We have chronic cholecystitis and acute cholecystitis. Chronic cholecystitis, all this means is that somebody has a chronic inflammation of the gallbladder. Typically, when people have this, they're going to get these recurrent but intermittent waves of pain, right? What's happening here is that, in the right upper quadrant where that gallbladder sits, what's happening here is that gallbladder is not working efficiently. It doesn't contract like it should. And so that the bile sits in there and it turns into that sludge. Or it could turn into a stone. Either way, when you have concentrated bile or you have a stone in the gallbladder, it's going to irritate that inner lining of the gallbladder. When that happens, that gallbladder is going to become inflamed. So you kind of get this recurring pain. Sometimes that sludge, sometimes that gallstone can actually plug up the cystic duct where it normally comes out of transiently. So it comes in, it comes out, it comes in. Maybe it gets stuck and then it goes all the way out, but it's going to be a reoccurring issue. These people may have some mild nausea and vomiting, but they're not going to be typically, not going to have a fever, not going to have leukocytosis because this isn't typically an infectious issue. It's just a chronic thing, chronic issue that somebody may say, hey, I've been having right upper quadrant pain for the last year, and then you go and you see the sludge in there, and maybe you see a stone, and then but it's not blocked, right? When you do an ultrasound, that gallbladder is going to be, the wall's going to be thick because that thing's inflamed, but you may not see a stone, or you may see a stone, or you might see sludge, one or the other, right? Acute cholecystitis is what we typically think of when somebody says they had a gallbladder infection, right? The gallbladder with this, you have this sludge or you have this gallstone, and then all of a sudden that thing plugs up that cystic duct. It plugs it up, right? This is going to cause severe pain when this happens because you get a lot of pressure that builds up when that cystic duct is obstructed for a while. These people are going to have, it's going to come on quickly and it's going to be constant. It's not going to be that typical wave-like appearance with the chronic cholecystitis. It says classically after a high-fat meal, because think about what the bowel is there for. It's there to break down fat. So when you eat fat, it sends a signal to your gallbladder to, hey, release your bowel so we can start breaking this fat down. Well, you just ate, and all of a sudden you got this pain that developed. Either sludge got in the way of that duct, or a stone got in the way of that duct, and now that thing is angry. You're not going to have jaundice with this, though, because the cystic duct is not the common bile duct. Cystic duct is bile still flowing through that common bile duct, and I'll show you a picture here in a second. So you're not going to have jaundice with this. When you have a stone in the common bile duct, you can, but not here. The bacteria, you do have bacteria that can sometimes transiently get up there into the gallbladder, so that can cause an infection. If that does, you get the fever and leukocytosis. And when you do your physical exam, that Murphy sign that you guys learned about, when that thing is angry, you have that patient exhale, and then you push in when they inhale, it's going to be painful, they're going to stop breathing. So they'll have a positive Murphy sign. But the ultrasound is going to look very similar to that of chronic cholecystitis. So here's a quick picture. So you got this blockage here, right? The pressure's increasing because the gallbladder, it has bile in it, but it also makes mucus. And when it's making mucus, that pressure is going to build up inside of it. Very similar to appendicitis. If that pressure builds up, it's going to start pushing on those vessels those blood vessels that support it. When you cut off that blood supply, it's going to become necrotic, and so that thing can burst. Down here below, this is an example of one without a stone. As long as this bile sits in there, it's going to turn into sludge. If that sludge blocks that cystic duct, which is this guy right here, right, then that can get in the way of it trying to be send out that cystic duct, which is going to increase that. You're going to have increased pressure from the mucus, and then that can cause the same kind of process with the gallstone. Okay. All right, almost done. So liver cancer, hepatocellular carcinomas. So this is more common in men than women. Think about it. Men tend to drink more. Men tend to do things that they're more prone to contract hepatitis B or C. And so you'll see this more in men than women, but women definitely can get it. Think about when we talk about the livers, when we talk about cancer, we talk about the anaplasia and the undifferentiated, differentiated cells. When these liver cells start turning into cancer cells, they become undifferentiated. When that happens, they revert back to their fetal ways, right? Remember, you can get these cancer markers. And so when people have liver cancer, they may start to develop alpha-fetoprotein, which is typically produced by a fetus in the womb. All alpha-fetoprotein is just albumin for the child. That's just a type of albumin for a fetus. But our cells don't normally produce that because we make albumin as an adult. When those cells start to revert back to their childish ways, they start making this alpha-fetoprotein half the time. The problem with this is that it's going to be very, very hard to diagnose this because think about your people who have this already, who are at risk of developing liver cancer. They have cirrhosis. They have chronic hepatitis. They already have GI stuff going on. They already have nausea, abdominal pain. If you're not tracking these people, if you're not constantly watching them and checking their liver and making sure they're not developing cancer, you may not catch it until it's too late. When it does form, if you're not tracking it, if you don't catch it, there's a very, very high likelihood of metastasis because a lot of blood flows through the liver, and that blood flows out of the liver and it goes elsewhere, and so it's very common for this to metastasize before you catch it. It's more common, however, to develop metastasis to the liver. This is way more common than actually developing liver cancer. Because why? The liver is a big blood filter, right? So cancer likes, or cells from other places like to go into the blood and eventually get caught up in the liver, so you're more likely to get metastasis to the liver versus a primary liver cancer. What's the other organ I told you about that is more likely to have metastasis? Lungs, right? Okay. So, if you see liver cancer, it's probably metastasis versus primary, but it could be either one. Here's what that looks like. A lot of things go to the liver. And we're done. Questions? All right, I'll be up for a little bit.